Assalamu alaikum. My name is Maria Hassan and I am the student of 5th of morning. I hold the seat number BP16500123. I'm here to present my presentation about Warfarin, which is submitted to Ma'am Shahana Wahid. Today I'm gonna discuss about introduction of Warfarin. Now, secondly, I'll discuss the toxicity of warfarin and its antidote. And lastly, I will discuss a case study along with the soap notes that would explain the usage and the prescription of warfarin as a drug. First of all, I would like to discuss the introduction of warfarin and give an overview about what is warfarin and how it is indicated and what are its side effects. What is warfarin? Warfarin is a potent anticoagulant commonly known as blood thinner. As we know, what are anticoagulants? Those drugs that helps to stop or prevent coagulation process. It prevents coagulation cascades. Therefore, these drugs are known as anticoagulants. This warfarin is a small lipid-soluble anticoagulant usually administered orally. It is, however, available in intravenous and parenteral form too, but primarily used as orally, so we called it as an oral anticoagulant. It reduces the formation of blood clots and helps in thinning the blood. Warfarin oral tablet is available as drug called Comedin and Gentovin. Warfarin is a drug that slows down the process of blood clotting, as I told before. Indications. Indications are those measures that a drug is used and how it is given to a patient. Warfarin is employed to treat blood clots such as deep vein thrombosis, pulmonary embolism, and or to prevent new clots from forming in your body. Preventing unhealthy and injurious blood clots help to reduce the risk of stroke and or heart diseases. As we all know, usually stroke and heart diseases, the underlying cause is embolism or blockage of the coronary arteries. So these blockage or of coronary arteries usually occur due to embolism and coagulation between the vessels. So this drug warfarin is highly and primarily used to stop this blockage and prevent the embolism and thrombosis. So we usually prescribe warfarin in deep vein thrombosis, which is the most common cause of heart diseases. Side effect of warfarin. Warfarin is we have two types of side effects of warfarin. Some are common and some are serious. First, I will discuss the common side effects. Common side effects of warfarin are related to abnormal bleeding. As we all know that it thinner the blood and helps in anticoagulation. So the most common side effect is abnormal bleeding. It leads to thinner your blood and that can lead to bleeding. So potential side effects includes unusual injuries such as unexplained abrasions, runny nose, bleeding gums, bleeding in the cut that takes a long time to stop. As you know, it's an anticoagulant, so it prevents the process of coagulation. So if we are taking warfarin and meanwhile we get a cut, it leads to long-term bleeding and the coagulation of process is prevented. It survives rather than normal menstruation or vaginal bleeding. As we know that in menstruation, the bleeding occurs. So if we are on warfarin, it can prolong the process of menstruation. Pink or brown urine, it is usually due to blood in the urine, which is commonly known as hematuria. Red or black stool, again, this is due to the presence of blood in the stool. The stool turns into red or black. Coughing up blood, cleansing blood, or things that look like coffee grounds. Okay, so what are the serious side effects? That serious side effects are those that really need an immediate consultant or supervision of a physician or a pharmacist. The most common side effect that possibly fatal is death of skin tissues. This can happen when blood clots form and block bleeding in your body area. Symptoms may include a charge in pain, color, or heat on many part of your body, pain, and purple or black color of your toes. It usually occurs because the blood is thinner and it is not handling properly. Symptoms as I read are purple and black color on toes. It is because the blood begin to uh, aggregate in the toes, and black coloration is due to the oxidation of iron in the feet. Mechanism of action of warfarin. Warfarin is a vitamin K antagonist, as we know that it prevent coagulation process. So it basically prevent the coagulation process by antagonizing vitamin K that inhibits the production of vitamin K. Warfarin competitively inhibits vitamin K epoxide reductase complex 1, an important enzyme that makes vitamin K active in the body. In this way, warfarin can reduce vitamin K containing reverses and thus reduce the concentration of active substances that leads to decrease in liver production that promotes clotting factors 1, clotting factors 2, 7, 9, and 8, and potent anticoagulant CNRS. The production of these substances by the liver depends on an adequate amount of vitamin K. If vitamin K is antagonized, therefore, the presence of vitamin K would not help to produce these factors, and therefore, the coagulation process is prevented. Drug interaction of warfarin. As we know that the drugs given on the simultaneously may interact with each other. So there are few drugs that hypothetically and officially interact with warfarin. So cytochrome P450 inducing drugs such as carbamazepine, phenytoin, rifampin, barbiturates increases warfarin clearance and reduces the anticoagulant effect of the given dose. As we know, that cytochrome P450 helps in the metabolism and excretion of warfarin. Therefore, it leads to it increases warfarin clearance, and hence the anticoagulant effect is not achieved. Cytochrome P450 inhibitors, as such as amiodarone, selective serotonin reuptake inhibitors, cimetidine reduces warfarin clearance and increases the anticoagulant effect. As you know that if we inhibit cytochrome P450, it will not increase the warfarin clearance, and therefore we can achieve the anticoagulant effect of warfarin. Antibacterial drugs such as I've mentioned, is metronidazole, trimethoprim, sulfur, methoxazole, and ciprofloxacin. These antibacterials are among the most common classes of medications that can interact with warfarin. Several theories have been proposed, such as eliminating gut bacteria that produces vitamin K2, which may lead to in reduction in warfarin antagonisms. This type of interaction is usually considered minor. Some substances directly affect the metabolism of warfarin due to CYP inhibitions. So, therefore, warfarin cannot be given with the cytochrome P450 inducing drugs, while can be given with cytochrome P450 inhibitors. Those adjustments those adjustments of warfarin is needed in adult if an adult suffers deep vein thrombosis and pulmonary embolism. The initiate warfarin dose should be on the day 1 and day 2 of parenteral anticoagulant therapy, that is low molecular weight heparin or unspecified heparin. Outbreaks appear to be exacerbated by warfarin and parenteral anticoagulant for at least 5 days until the INR, uh, which should be greater than 2, is maintained for 24 hours, then discontinued parenteral treatment. As we all know that the most potent way of treating these diseases, DVT and PE, is oral warfarin. But however, to achieve an effect and maintaining INR immediately, we require low molecular weight heparin, which is given parenterally. Similarly, in stroke and thromboembolism, initial dose is 2 to 5 mg per oral per IV once day, till given for 2 days, or 10 mg per oral given for 2 days for healthy people. Check the INR after 2 days and adjust the dose according to the result. The usual dose limits are between 10 to 2 to 20, 10 mg per day. Pediatric, if a child suffers thrombosis, if baseline INR is 1 till 1.3, administered loading dose of 0.1 to 0.2 mg per kg per oral day once every day. Check INR on days 2 to 4 and adjust daily dose to maintain INR between 2 to 3 unless valve replacement indicates a higher range. Typical maintenance dose 0.09 to 0.33 mg per kg per day with infants smaller than 12 months old often require doses at higher end of range. If he talks about geriatric patients in thrombosis, low doses are required to produce a standard of anticoagulation treatment. Initial dose should be lesser than 5 mg per oral per day once daily. Dose maintenance should be 2 to 5 mg per oral once daily. If we talk about dose modification, first we come to pregnancy. Warfarin is generally not recommended during pregnancy. It can be effective to the baby, especially during the first 12 weeks of pregnancy. As we all know, it is an anticoagulant and it thinners the blood. It can cause harm to the baby and leads to menstruation. Hepatic impairment, maybe a strong response is produced to warfarin due to decreased metabolism and impaired production of clotting factors. As we know that if someone is hepatically impaired, so the clotting, the factors produced by the enzymes produced by liver are also affected. Therefore, dose modification would be needed. In renal impaired patient, no dose adjustment is required in patients with renal compromised patients. Monitor INR frequently in patients with reduced renal function to maintain INR within the treatment range. Warfarin brands available in Pakistan with respect to pharmacoeconomic point of view. There are other than these, there are also some other brands available in Pakistan, but the most commonly used are Warfarin, which is available in injection and as in tablet. 5 mg vial is present as in parenteral form, while 2.5 mg, 1 mg, and 5 mg tablet is present in the tablet form. Similarly, Ferricard tablet is present in 1 mg and 5 mg dose. Warfarin is available in 5 mg tablet. So, coming to my second topic, toxicity of warfarin and its antidotes. As we all know, every medicine is a drug, and more usage or somehow due to interaction of the drug, there can be any sort of toxicity which can create rather than serious side effects. Toxicity of warfarin. Warfarin toxicity occurs when there is too much of warfarin in the body. Some of the changes in the diet and medication can result the toxicity of warfarin. Warfarin toxicity can cause life threatening bleeding. To treat this life-threatening bleeding and toxic effect of warfarin, we have treatment for patients who are suffering from warfarin toxicity. The treatment will depend on the INR and the presence of bleeding. The first step in the treatment of a patient is to abort the use of warfarin and consider administration of vitamin K. As we know, warfarin antagonizes vitamin K. So, in while providing or administering vitamin K can helps to reverse the effect of warfarin. Therefore, it is the antidote of warfarin toxicity. Warfarin, for warfarin toxicity, vitamin K is significantly used to counteract the effect of warfarin. If INR is greater than 10 with no bleeding, then oral vitamin K 1 to 5 mg solution is administered. In case of oral vitamin K, it may take up to 24 hours to fully antagonize the coagulotherapy induced by warfarin. In case of bleeding, intravenous injections of vitamin K can be given. Usually, this is from 1 to 10 mg per day, depending on the severity. Intravenous vitamin K administration may often be reverse coagulative therapy within 4 to 6 hours. Subcutaneous vitamin K should be restricted to certain patients, such as vitamin K is a fat soluble vitamin and is sensitive to the weak absorption from the subcutaneous tissue. However, if we are not achieving the our required INR range and an immediate reversal is needed, we jump to fresh frozen plasma therapy. In this, we could treat a patient with fresh frozen plasma. However, this administration might take up to few hours. Toxicity can also occur due to irrational use of warfarin. The irrational use of warfarin leads to toxicity and severe adverse effects such as persistent bleeding, which could be fatal. It can cause internal bleeding and may lead to excessive vitamin K deficiency. Vitamin K is required for coagulation. So, if we are using warfarin irrationally, it can lead to vitamin K deficiency and on need of if there is scar or wound that really needs to be healed. So it will prolong the healing time too. Alternative choice of drugs to warfarin. There are new anticoagulants called dabigatran, rivaroxaban, and apixaban. This does not require the monitoring of or adjustment of the dose and act as warfarin in preventing blood clots. Their advantages are simpler than more major advances in safety. However, the way they work in the body is different from the way warfarin works. Of course, their targets are different. They affect a different part of the thickening process. But these differences often make a new drug easier to use. There are many benefits of using these medication on comparison to warfarin. They start to induce their effect faster as you induce the treatment, and their effect are not long last adverse effects are not long lasting after you stop taking them, so they provide a benefit to the patient. You do not need to have a lot of tests to see whether or not a blood thinner the level is within the normal range. These medicines will have less adverse interaction with other medications, and they are not affected by diet or dietary changes. Therefore, these drugs are alternatively used against the warfarin. Lastly, would like to discuss case study with SOAP notes. As you know, SOAP stands for subject, objective, assessment, and a plan. Case study: Mr. W is a 52-year-old, 50 kg overloader in the local wool mill, was referred to hospital by his general practitioner with a red swollen left leg. He said that he had not knocked his leg, but that it had just come up during the night. He had recently returned from a coach trip to Scotland. He had taken some painkillers before going to his uh, general practitioner. Mr. W.'s past medical history revealed that he had been started on co-amylofruse 5 by 40, which is amyloride furosemide, 6 months earlier for mild breathlessness on exertion. On examination, Mr. W.S. was found to be short of breath with a regular pulse and a raised jugular venous pressure. His calf his left calf was inflamed and painful to touch. When measured, his calf circumference for left leg 39.5 centimeter, right leg 36 centimeter. His left thigh was also swollen and he had pitting edema on the left leg. He had a raised D dimer. Chest X-ray showed some fluid retention and he was hemodynamically stable. A two-level Wells score was done, which showed a deep vein thrombosis was likely, and this was confirmed on proximal vein ultrasound. He was diagnosed as having a left deep vein thrombosis and mild left ventricular failure. This was considered to be provoked DVT linked to his recent coach journey. Subjective. Our patient's age is 52 years old. His weight is 65 kg. His gender is male. Medical history revealed that he has been started on co-amylofruse 5 by 40 6 months earlier for mild breathlessness and exertion. Current medication is co-amylofruse 5 by 40. Objective. The vitals, however, some of them are not given, but it can reveal that the patient has regular pulse but has raised jugular venous pressure. His left leg is swollen. Calf circumferences were left leg 39.5 centimeter, while right leg is 36 centimeter. He had laboratory chest X-ray that revealed fluid retention. Two-level well score. It is a test usually used to identify and reveal deep vein thrombosis. So this test was done for Mr. WS, which showed deep vein thrombosis, which was later confirmed by proximal vein ultrasound. In our assessment, we have come to the point that Mr. W has had a red swollen left leg, and which was just appeared in a night. His medical history also shown that he was taking co-amylofruse 5 by 40 since 6 months earlier for mild breathlessness on exertion. On examination, we have found that his left leg was swollen and his pulse rate, however, was normal, but he has jugular venous pressure elevated and his left leg swollen and painful and the circumferences were elevated of leg as compared to right due to edema. His chest X-ray revealed fluid retention, while two-level well score showed DVT, which was later confirmed by proximal vein ultrasound. From all the tests and examination, we can conclude that Mr. has deep vein thrombosis and mild left ventricular failure, which could be linked to his recent coach trip to Scotland. Our plan surrounds, first of all, about the medications. We will continue the usage of co-amylofruse tablets 5 by 40 once daily, every day, because co-amylofruse is a combination of furosemide and amyloride. So amyloride and furosemide both are very potent diuretics that helps in the excretion of that fluid which is retained in the leg due to edema. Similarly, we will begin the anticoagulation therapy to treat deep vein thrombosis by using tinzaparin injection, which is a potent low molecular weight heparin. An injection of tinzaparin injection 14,000 units subcutaneously will be given once daily till warfarin effect overlaps. As I have discussed earlier, that to achieve an early effect of warfarin, we always require a low molecular weight heparin that helps to maintain the INR within the range, and warfarin to produce an effect. So, along with tinzaparin, we will induce therapy of warfarin loading dose, that is 5 to 10 mg given up to 3 days until INR is maintained in the desired range, that is greater than 2. We will give the dose according to the INR monitoring when warfarin effect is induced, which will definitely take up to 3 days. So till 3 days, we will continue tinzaparin and warfarin side by side. But when the warfarin effect is induced, we will stop tinzaparin, and maintenance dose of warfarin can be given, which is 2.5 mg per oral. Which will, and this treatment will be continued up to 3 months, and till the treatment is continued. If there is pain and which is very severe, so ibuprofen could be given to as a painkiller to reduce this pain. Ibuprofen 400 mg per oral twice daily can be given only in case of pain. General recommendations can be made, which is basically linked to the medication. So first of all, regular INR monitoring is required until INR is within the range, and when it gets in the range, we can reduce it to 2 to 3 days interval, and we can just check after every 3 or 4 days the required INR range, just to check whether the INR is in the range or moving above the range or below the range. So, INR monitoring is very necessary while giving warfarin. No coaching journeys should be taken up to 3 months, as the DVT is linked to his coaching journey. So the patient should avoid coaching journeys, and the embolism could be due to oily foods too. So the patient should avoid oily food and barbiturates, because oily food would affect the metabolism of warfarin, and barbiturates are CYP 450 inducing drugs. So it will increase the clearance of warfarin, which will lead to reduce anticoagulant effect of warfarin. If any bleeding appears, consult the doctor immediately. So in this all the presentation, we've learned so far that warfarin is an anticoagulant which is potently used to thinner the blood. It is given with the low molecular weight heparin to induce its effect, but when its effect is achieved, we will immediately stop low molecular weight heparin, and warfarin maintenance dose is prolonged and up to 3 to 4 months within the until the INR is within the range. Thank you.